I think one of the most devastating things for people when you're diagnosed with lung cancer and you get on the internet and you read about all of these great advances is when your doctor tests your cancer or you have your cancer sent off for mutation profiling and it comes back with none of them. And this is really hard for people. This still remains the biggest group of people, but there are some advances, including advances in 2012, that I think really show promise even for people who don't have all of these mutations that I've been talking about and that there's so much information about and excitement about in the literature. So I think people who really feel the difference between new treatments and not are those people with squamous cancer. Currently, the standard treatments for squamous carcinoma are really limited to our current best chemotherapy options, and we've learned a bit about what the best types of chemotherapy are for someone with squamous carcinoma. In particular, Alimta is not as helpful, and so we actually stick to non-pemetrexed or non-Alimta-based chemotherapies. But there's been a lot of work ongoing with the Cancer Genome Atlas to really take a good look at squamous cell carcinoma and really see what we can find in terms of new potential targets. And the exciting news is that there have been targets that are identified in up to 3/4 of patients or more. Some of these include P10 abnormalities or PI3 kinase abnormalities, as well as a number of others, including fibroblast growth factor receptors and others. It's interesting, we're learning that squamous cell carcinoma, just like adenocarcinoma, is not just one type of cancer, and it appears that there are probably 4 very big groups. And for people who know a bit about breast cancer, you'll know that there are these larger clusters of different types of breast cancer, things like luminal A and B and basal cell, and we are seeing a very similar breakdown in squamous cell carcinoma. So most people have what we're calling for now classic squamous cell, and this has classically certain abnormalities. You might be more likely to have changes in fibroblast growth factor receptor kinases, methylation or changes that turn off or silence genes that should be working to protect people, as well as some newer abnormalities, things like NFE2L2. I've got it down here in case you forget, and KEAP1. And so we don't know all of the targets. We know that we have drugs that can target FGFR, but we're still learning a bit about some potential options to target this. Similarly, platelet-derived growth factor receptor is a potential target in about 1/4 of people with squamous cell carcinoma, and a smaller number of people have more primitive tumor types. RB1 stands for retinoblastoma, which we do see as abnormal in a number of other cancers. And so it's quite possible over the next year or two that we're going to be able to break people's cancers down into 4 groups and say, this is your potential best treatment approach or the potential best options for you in terms of trials going forward. In particular, looking at trials that are out there, people that have an excess number of FGFR genes in their cancer or have mutations might be candidates for FGFR inhibitors or blockers, and there are a number of trials ongoing looking at this. There are drugs that are out there trying to target what we call PIK3CA or P10 as a pathway, and I've listed one here, but there are others as well as other options. We've seen BRAF mutations, and so people could potentially access BRAF inhibitors, abnormality in DDR2, and there's a drug for that as well, dasatinib, with ongoing trials, as well as EGFR, which is overexpressed, and also in squamous cell carcinomas. These are different than people with mutations, but perhaps some of these newer EGFR inhibitors that we talked about before might be good options. So in people who don't have mutations or where the mutation profile isn't known, there's been a lot of excitement about immune treatment. And we've learned now, and this is a complicated cartoon, but we've learned that cancers have the ability to turn off our normal immune defense system. They're able to secrete certain hormones that initially activate your T cells. These are the cells that we rely on to attack our cancer, part of our immune surveillance. Normally what happens is with signaling, we get a real expansion and activation of all of these cells that would go in and kill a cancer or provide some surveillance. What cancers are able to do, though, is they're able to actually turn on receptors on our lymphocytes and T killer cells to try and kill the cancer called programmed death 1 or PD1. And they're able to do that with a ligand, something that turns on a receptor or plugs into a receptor to start a signaling pathway, PDL1. So this has become really exciting, and there's a monoclonal antibody that's been developed that targets PD1 and tries to block this loop here where the tumor is actually able to turn off the immune system. So the thought is, if we block this with this anti-PD1 or there are even anti-PD-L1 antibodies, can we allow the immune system to do its job and fight cancer? There's a very exciting study presented at ASCO, and it's also been presented in the New England Journal. And Dr. Bramer was the first author of the lung study. This is also being developed in other cancers such as melanoma, kidney cancer, and colon cancer. And what's interesting, people got this antibody every 2 weeks for about 8 weeks. And initially, this is somebody with adenocarcinoma, you see a little growth. But then by 4 months later, and this is finishing treatment, you actually see very nice regression. And some people have had really prolonged shrinkage of their cancer. And it's pretty minimally toxic. Some of the side effects can be significant, so you can only get this as part of a clinical trial, and you do need careful follow-up. But this is potentially a really exciting approach. Now, I apologize, I've got some numbers here, but I think what I want you to take away from this is the fact that this doesn't just work in adenocarcinoma, where we do see shrinkage rates in about a quarter or 10% of people at different doses of these inhibitors. We also see activity in people with squamous cell carcinoma. So very, very exciting and a potential option for people with both key types of lung cancer. And it's interesting, here in these black lines, these are people with squamous cell carcinoma, and this is cancer shrinkage where you start at time 0, and you actually see a lot of cancer shrinkage in people with squamous cell carcinoma. So a lot of these studies are ongoing in people with squamous carcinoma, but of course there's also some benefit seen in people with adenocarcinoma or non-squamous.
Thanks for listening. If you like and learn from our GRACEcast, you can subscribe on iTunes by just searching for the term Cancer Grace, find podcasts in the subject you want, pick a format of audio or video, and then just click subscribe. It's that easy. And for those of you who don't want to miss any of our programs, there's even a feed for all subjects. You can also find us on YouTube at Grace for Cancer Info, and that's the number 4 in one word, Grace for Cancer Info. Finally, if you haven't been there yet, please check out our Grace website at www.cancergrace.org. And don't forget that donate button in the upper right. Our content, which helps tens of thousands of cancer patients around the world every month, is made possible by your support.